Good evening, everyone, and welcome to our Culturally Responsive Mental Health Care webinar. My name is Dane. I'm from Central and Eastern Sydney PHM, working as a project officer. Firstly, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water, and community, and pay respects to elders past, present, and emerging. I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. The following services will be available, and I firstly like to acknowledge that the Central and Eastern Sydney PHN stands in solidarity with all those affected by the recent tragedy in Bondi Junction and extends a heartfelt condolences to the families and friends of the victims. The next following slides will have some services that are available to you and your patients. So please, if you'd like to take note of them and then distribute them as required. Your Coach Plus is a great free and confidential mental health service coaching program. There's no referral needed, and clients can refer themselves as well. Head to Health has the drop-in service at Canterbury. And they're open Monday to Friday, and there's no appointments or referrals needed. You can just pop in. We do have our telehealth psychiatry service, which is a free service with psychiatrists via telehealth, and you can make a referral with the link there and on our website. Our mental health service directory is a new addition to CESPN, and it can assist you to help find mental health services for your patient using a variety of filters and wait time functions to find the best service which is needed for your client. Emotional wellbeing for older persons. It provides psychological and psychosocial services for older people who reside in residential aged care facilities in the Sydney and Southeast Sydney L8 local health districts. Please email or call the line there to make a referral. So I'd like to introduce our speaker for the night, Emalynne So, who will be presenting on culturally responsive mental health care. Emalynne is a mental health consultant at the Transcultural Mental Health Centre and works specifically in the refugee mental health program. Her focus is on clinical services capacity building with refugee populations, and she is a clinical psychologist who has worked with migrants and refugees across the fields of chronic pain, medical rehabilitation, and psychological medicine in public and private settings. So without further ado, I'll hand over to you, Emalynne.
Thanks, Dane. Hopefully you can see my slide as well before I start and you can hear me okay. All right,
Perfect.
awesome. All right, thank you for the introduction. I'm Emalynne, as Dane mentioned, and I work at the Transcultural Mental Health Centre, and we're a statewide New South Wales health service, and we work with CALD communities and health providers across New South Wales to support good mental health. And I'll talk more of it later so that you can kind of see how we might be able to support you in your work. I guess the other thing to mention, as I'm not going to go through all my experiences, Dane has already done that, but it does influence my terminology. I've used patient, client, and there's also consumer within mental health services, but I try to use individual as much as possible, but just letting you know in case you pick up on my language. The other thing is it's also helpful if, so the talk's about 1.5 hours. There's a scenario at the end, and there's about 10 or 15 minutes, hopefully at the end for some questions if you've got any questions. The talk is quite content heavy, but I like it to be as interactive as possible. So there are some activities for you to respond to. You can do that via the chat box. I'm not sure whether you can mute or unmute yourselves, but at least the chat box is available to answer some questions throughout. The other thing, I guess, is because when we talk about CALD communities, we also talk about refugees and asylum seekers. And there's going to be some, I guess, in terms of content advice, there'll be discussions around some difficult issues such as trauma, suicide, self-harm. And if you need to take a reflective break, please do so. And you're more than welcome to get in touch with me afterwards as well. And now my screen's playing up that I have no idea what's going on. All right. Okay. And we'll have my contact details at the end as well, so that if you wanted to get in touch with me or provide feedback, you're more than welcome to. So I just wanted to say that I live and work on Darug land, and tonight I am on Darug land, and I want to acknowledge their people as traditional owners and ongoing custodians of the land, and I pay my respects to their elders, both past and present, and I also welcome any First Nations people who are with us today. And as we are online, I also want to acknowledge the other traditional owners and custodians of the lands that you are joining from as well. And so, from the world's oldest continuous culture of our first Australians to the cultures of our newest arrivals from around the world, TMHC embraces and celebrates diversity. So, I also acknowledge those with lived experiences as migrants or as refugees, and those with the lived experience of mental health issues, and the courageous journeys of many generations of Australians who have made Australia what it is today. So the overall aim is an introduction to building skills, knowledge, and confidence in engaging with culturally and linguistically diverse communities, including people with migrant and refugee experiences. So to provide culturally responsive mental health care. So to start with, I will try to, I guess, build that context by describing the cultural diversity within Sydney, or in Australia, New South Wales and Sydney, and then the experiences of CALD communities in terms of their definitions of those experiences, demographics, and some prevalence data. And then I'll explain how culture influences mental health and illness. So talking about things like shame, stigma, emotional expressions, migration, and the historical context of that. And then also looking and then going through some tools, resources, and services that can support CALD communities. So we're looking at that in two parts, looking at what we can do or how we can be when we're engaging with a CALD community. So having that culturally responsive mental health care. And then also looking at resources, looking at cultural assessment tools, translated tools, and also some of the tools that you can get from TMHC as well. So what I guess I want you to do is really to think of a patient or a client or an individual that you've seen while going through the material, and that might help generate some questions that you might have. There might have been someone already in particular that you've been thinking about, and that's what's brought you here today. And on the next slide, I'm actually going to share someone's individual story, and we're going to go back to her throughout the talk, and then at the end review some of those issues. And so we're going to meet her in a second. But I guess one of the other things is about this session, it's really aimed at building your skills and knowledge to work cross-culturally, as well as improving that understanding and bridging of cultural differences. So it's not really about describing specific cultures, their beliefs and values, because we want to be able to work across all cultures, given the diversity in Australia. So if you don't have someone that you've got in particular that you have in mind, then here's someone to think about. This is Aruna. Aruna is a 56-year-old female, originally from Sri Lanka. She presents to you with excessive worry about her life situation. She can't sleep anymore, and she's only getting about 3 hours sleep each night. She is known to you, but this is the first time she's disclosed a great deal of personal information. She has no family here in Australia and has just one friend that she speaks to on the phone who lives far away from her. When asked about her family history of mental illness, Aruna says that her mother had anxiety and took medicinal herbs to relax. Aruna reads in her language and watches Sri Lankan movies and goes regularly to the local RSL club to play bingo. She does not drink alcohol due to her religious beliefs. With regards to medical history, she has type 2 diabetes and arthritis in the knees and a bad back from her cleaning work over the years. When asked about mood, she says that she feels down and worried and cannot relax or concentrate and is fearful about the future. She's not thought about suicide, but she's very worried about her situation. She can kind of have a bit of a picture of Aruna, and we'll come back to her as we go through the slides. So just to, I guess, recap and make sure that we're, I guess, all on the same page around what culture is, there are multiple meanings and definitions, but the anthropological concept related to how people live may be the most useful. And it's thinking about culture that develops on a social level. So it's a society level phenomenon rather than on an individual one like personality. So it gets passed from human to human, we learn from others and pass on what we've learned. So there's this evolving human culture. So culture is values, norms, beliefs, attitudes, and more, forming patterns that distinguish one group of people from another, be it a country, a region, an ethnicity, or some other group. So it's understanding that culture is more than just race and ethnicity, but also other aspects. We can think about gender, age groups, particular occupational groups, comparing sort of, doctors, psychologists, nurses, or our workplace between primary healthcare, hospitals, community health, or even where we live, our eastern suburbs or western suburbs. So all these different aspects influence that person in front of us and their difficulties. Culture can teach us how to think, feel, act, and also how to interact with others, and also how we might interpret the behavior of others. Consider that point in relation to our work with individuals, because I know when I've some of the nonverbal behaviors like eye contact can also impact someone, or the way that, I've had someone who shake their head and they're actually agreeing with me, but what we know in Western culture, usually the shake of their head means that we're not in agreement. So sometimes it's having to try and work through that. So language facilitates our social interaction while culture shapes our social interaction. So when we think about that and all these other aspects, everyone has culture. It applies to all people. And using the term culturally and linguistically diverse people seems to limit this. And we'll talk a little bit more about the terminology in a moment. So the question to ask is, what about us? I'll give you a couple of minutes to just think, or maybe 60 seconds to think about, like, what aspects of culture are important parts of your identity. So I want you to kind of just sit there for a sec and just think about the implications of that culture in your work, your values, your beliefs, your attitudes. And you don't need to share any specifics, but I just want you to kind of think about and maybe share in the chat box what that process was like for you. To share what the process is like. But I guess one of the things is you can think about how, for example, how in your culture you might deal with emotions. Okay, I've got Nahid, thank you for sharing about religion and your beliefs. Yep. And that's important aspects that are important part of your identity. I don't know if anyone else wanted to share. And I'll just continue with my example about how you might deal with emotions, might impact on what kind of things you might focus in your, I guess, interviews or discussions with clients if you're not sort of comfortable talking about emotions, because it might be something that's not spoken about in your own culture. Someone has put values and beliefs. And to give a couple more, I don't know, 30 seconds or something for someone else to join in on the chat. Thinking back to Aruna, how would she perceive you if you were culturally, I guess, from the same sort of background? What kind of expectations might you have if she thinks you've got the same values and beliefs and attitudes? Or how does it look like if you do that cross-culturally? What kind of things do you need to kind of think about when you're doing that with someone of a different background? All right, trying to click through. All right. Okay, so how might culture be thought about in the mental health care context? So firstly, we think about the definition of transcultural, sorry. So the transcultural paradigm identifies and acknowledges that interaction of cultures. So you can enable that building identity from race, ethnicity, gender, and that freedom of belonging to many cultures, so that you can build that sort of equal partnership, equal attention and respect to cultures of both parties in an interaction. So when you compare the term transcultural to cross-cultural, we're kind of thinking about cultural groups as being compared and contrasted, whereas transcultural kind of goes beyond comparing characteristics between cultures and beyond those barriers. And multicultural, when we think of that term, which we use a lot, seems to restrict individuals to one particular culture and seems not to imply that there might be diversity within and between ethnic communities. And you can think about someone that's come from a refugee background. It prevents sort of those oppositional cultural identities that might occur within a country, and that they could be potentially persecuted because of their ethnicity or religion. So when we look at Australia, which has a significant migration history, cultures are merging and converging, and the migrant's journey of culture is basically quite dynamic and evolving. So people undertake this transcultural experience that impacts them and their descendants, and these factors can influence the mental health. So it's an intergenerational sort of impact. And so I feel like the transcultural paradigm is a really great way it's a real great thing to use to help acknowledge that intersection of identities, and it contextualizes a person's expressed levels of distress, help seeking pathways and attitudes towards services provided. And I guess in our roles, to help support individuals succeed, we must understand the lens with which they are perceiving the world. And we can think of, I guess, like a hybridity of cultures that might cause conflict for that transcultural migrant who's trying to navigate two or more cultures. And you can think of teenagers who might be growing up developmentally. So they've got that developmental stage they're going through, and then trying to navigate sort of their home culture and their culture with their peers, sorry, and how that might be for that person and how that might impact their emotional well-being. So it's really considering the person's frame of reference, their transcultural lens. How might others identify themselves? How might others identify us? And how might we identify ourselves? What's our transcultural lens? Is it through language, country of birth, religion, sociocultural upbringing, race? So really need to consider these concepts in our work where we're engaging with people, communicating with others. So I guess, so who are we talking about? So to provide context around cold Australians, I'm just using some census data from 2021. There's over 7 million migrants living in Australia. And when we count, I guess, people that have at least one parent overseas, it'll be over 50%, with the top 5 countries of birth being China, England, India, New Zealand, and the Philippines. So I won't read out the other things on the screen. They're just, I guess, different aspects that we can think about when we're talking about cold communities. But the one that I'll highlight is the growth communities, where what we've seen is that the top 5 countries of birth, which is up there, there's been a growth of greater than 20,000 people from the 2016 census and the 2021 census. And what I guess I'm trying to emphasize here is basically the diversity in our society, in Australian society. But what it only highlights, though, and I guess it's limited by what we can get in the census data, is that definition of cold communities, because we're only talking about a few aspects here. And usually when we're talking about the census data, it's around, the ancestry, the language, countries of birth. But we're also thinking about religion. And when we're asking someone their country of birth, that doesn't necessarily mean that they're of, say someone's comes from England, it doesn't mean that their ancestry is English. They could be born in England, but be of Indian ancestry and speak multiple languages and may not have any particular religion. So when we're thinking of a person, we've got to think about how they describe themselves and how these different aspects of being a person of the cold communities might influence their presentation in terms of potential mental health issues. So I won't, New South Wales sort of demographics are a reflection of national sort of demographics. And within CESPN, within the Central East Sydney sort of community, what we see is there's, a significant more number of people that are born overseas, and those having one or more parents born overseas, that goes up to about 66%. And we've just got, I guess, a slight change in the countries of birth with China, England, and we've got Vietnam, Lebanon, and India. And the languages are, I guess, the same. What's I guess something interesting to note is about 40% of people speak another language other than English. So really, I guess, highlights again that diversity and the importance of the work of people like us that work with cold communities and clinicians to sort of build that capacity. So before we look at the prevalence, I thought I'd just do a quick reminder and review of what we mean by mental health, because sometimes people will misuse the word mental health. So mental health is a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to his or her community. So when we're talking about mental health, it's an integral and an essential part of health. And it's more than the absence of mental disorders or mental illness. And indeed, there is no health without mental health. And it's really fundamental to our collective and individual ability as humans to think, to show feeling, interact with others, and earn a living and enjoy life. So what might sort of the, I guess, the research say about the prevalence of mental illness and services used by COLD communities in Australia? Um, there was a report written almost 14 years ago, but not much has really changed, unfortunately. But what it found is that oh, I don't know why things have just disappeared. The report found that there was considerable gaps in the data on prevalence of mental health disorders. And there's no real research that's comprehensively in Australia adequately captured the data on COLD communities. And there's a lot of issues, I guess, around how data is captured, which is what I've just said around language, country of birth, what sort of variable do you use, as well as how it's not a homogenous group that we're talking about either. And there's a lot of, and I guess what we'll be talking about in a moment as well is some of the issues as to why someone from a COLD community may not actually front up to a mental health service. But what the limited data suggests generally in terms of immigrants, refugees, and asylum seekers is that there's lower rates of mental health service use versus the Australian born. They're overrepresented in involuntary acute inpatient admissions, and they'll be potentially be more likely to be exposed to quality and safety risks because there might be misunderstanding and misdiagnosis due to language and cultural barriers. And in diverse cultures in countries like Canada, the US, and here, people seek help much later than those from the general population and present in acute stages of mental distress. And so why might this be the case? And so we need to kind of think about three broad issues when providing care. It's about accessibility, so that is it, the practical accessibility, understanding, and we'll talk about sort of ways to sort of help them understand what's going on in terms of mental health issues and mental illness, in terms of translations of information, so that cultural adaptation of services, supporting that person within their cultural context, whilst within our system of care, and also broader social determinants of health, which is a bit beyond the scope of today's introduction, but noting that there's issues around health equity and health and human rights. But I guess what we want to note here is that there are variables outside of a person's control, like discrimination, that might impact a person's mental health and may not want to access services. And I guess that's, and I guess one of the other things and the reasons why we're here is trying to work out what are the cultural implications on mental health. But before that, we'll just go through just to take a brief look at migration experience. So when we're thinking about the migration experience, we can consider that in three parts: the pre-migration, the journey itself, and post-migration. And each has their issues to consider in the context of mental health and mental health issues. But this isn't an exhaustive discussion, but I just wanted to highlight a few things. So, when someone, leaves their country of origin, we're talking about push and pull factors. It might be economical, trying to find employment, better opportunities, psychological or political, reuniting with family, a better lifestyle, or it could be more related to freedoms. They might be marginalized due to their ethnicity or sexuality or religion, or there might be natural disaster in terms of climate change that's impacting where they are. And things could be happening on a macro, meso, or micro level, so impacting them at the society level, where there might be war or a group with, as I mentioned multiple times already, that ethnic persecution, or it could be on the individual level, finding another way, education opportunities. And then we can think about, and you can just see where potential issues could occur for someone in terms of their mental health. Then we look at the journey itself, that level of stress of moving, but it might be more of a issue for those who might be seeking asylum because there might be ongoing trauma and human rights violations in their country that they've transitioned to, between the country they were from to the country they're trying to get to. But overall, when we're thinking about migrants in general, we're thinking about potential triggers to their stress, I guess, sort of a psychological or stress vulnerability. So it could be that, if something else happens to them, they'll be more likely to be affected by stress. And then thinking about the post-migration experience, settlement's sort of that time of adjustment. It can be multifaceted and complex. And there's, different sources of stress, socioeconomical, political, and, which could be, examples, the racism, discrimination, that could be through social media as well. And also thinking about the cultural context, those different rates of acculturation. There could be potential intergenerational conflict as well, where parents are usually the head of the family, but then they find they've got to rely on their children for translating and interpreting with government services, for example, and then that can create that change in that power difference, which can cause conflict within families. And then when we think about the forced migration journey, we've got to take that sort of trauma-informed, holistic approach, because the migration experience is going to be quite different from the refugee or asylum seeker to other migrants, because they're forced to leave rather than having the freedom to leave and being able to potentially return if they wanted to. In that context, they can't. In most parts, and having sort of that clear impact on their mental health as well. So I guess the migration experience can be very different, very individual, and lives are impacted regardless of what the story is. So I guess putting it together, culture can influence how mental health is experienced, help-seeking behaviours and access to services, and migration experience is the context for culture and mental health intersection. So it's that frame of reference of their social context and norms that might not necessarily be Australian culture. And we can think of migration as a process, not a single event. And what we see is that culture evolves through that acculturation process and through the migration experience as well. And so we can think through the migration experience that this vulnerable population in developing mental health challenges with migration, and that can impact on a person's well-being. And I guess another thing when we think about parents, migration is another way where they might be trying to provide a better future for their children. And this pathway can be often very challenging to migrant parents. Just really briefly that, they have to deal with those normative challenges of parenting while also having for themselves to adapt to these new norms, values and expectations. Okay, so what are the cultural implications in mental health and illness? So might be aware of some of these, and I guess I want to go through what you might do if you see this in the person that you're seeing, your patient. So there might be shame and stigma. The reputation of the family might be they don't want to tarnish it, so they don't want to attend mental health services, and they might not open up and won't actively seek treatment despite their suffering. So what might you do? It's about normalizing mental health issues. It's asking questions that might be less intrusive. It might be asking about starting with physical symptoms or activities like, checking in on appetite, weight change, sleep patterns, energy levels, or what they're doing on a day-to-day basis. And that might lead to more questions to sort of establish a potential diagnosis of mental illness. It might be their understanding of mental illness. There might not be even a definition in their language or culture, and and their attribution of cause might be different as well because of that, and the symptoms they might show. They might not adhere to the taking of medication or accept any sort of psychological counselling as well. I had a client who was very fatalistic around her illness trajectory, so didn't see what the point of seeing a psychologist was, but had a need to, what I had to do was spend a lot of time trying to educate and explain, even providing written translated information to give her, I guess, to normalize her experience as well, that, having something in another person's, in their own language can go, okay, maybe I'm not the only person that suffers from these same symptoms and issues and illness. And when we're talking about, so I did mention symptoms, thinking about their emotional expression, it might be quite different. Some might talk only about physical symptoms or emotional symptoms or both, or they might downplay it and might not say anything at all. So they might have So it might be suggesting, I guess, things for them to do that might fit better with their cultural beliefs. So they don't want to disclose or they don't want to talk about it, then maybe it is starting with, it might not be about recommending to see a psychologist straight away. It might be providing information to read or more active or physical exercise like walking or something. And if we think about Aruna, considering her symptoms, what she was open to talking about, and thinking about how then would we navigate that conversation with Aruna. Although she seemed to be quite open around sort of more of those emotional symptoms, thinking about worry, but also she did speak about sleep. So thinking about what can we provide in terms of support around that in the very brief time or little time that we might have with her. So what else might we have? There might be a lack of knowledge and understanding of services. So there could be back in their origin, their culture of origin and heritage, it might be a completely different system. And so they may not be able to understand what each service does and what's available to them. It could be just a linguistic barrier, just the language, the English proficiency is not so great. And so it's hard to navigate the system. I mean, for some people that are English speaking with qualifications, it can be really hard sometimes to even navigate. There was an article recently, I think, some about trying to contact Centrelink, and they said they were well educated and English speaking. So that, that a sort of simple thing makes it very hard for people that are then from cold communities or don't have English as their first language. Thinking about what their different priorities might be. They might think basic needs first. A parent might want to work out what's going on for their child before putting themselves first. If it's someone that's newly arrived in the country, they might want to work out where they're going to put their child in what school, and they've got to find out where they're going to live first before they even think about managing any mental health issues they might have from trauma they might have seen as part of their pre-migration experience. Their perceptions of interventions as well. There might be a lot of stigma around taking anything that might be pharmacological, so medications, or they might not really understand what psychological interventions do, and it might need some psychoeducation around that so they can understand how that might be able to help them. So it's really a lot about education, and some of the things that we have on our website is translated information around explaining some medications, and in particular, I think antipsychotics, I think, is one of the things that we have that is explained in some languages. So that might be easier to explain sometimes, even if you might provide someone an explanation in their language or in English or with an interpreter. Sometimes taking something away in written form might help, especially if they're under a bit of stress. Or if you don't have the time to provide that explanation either in your consultation. And then coming to the migration experience, culture evolves within the context of the migration experience. And in terms of a forced migration, they might not have been able to access services. They might not access services because they've had, poor experiences in the past with authority figures. And so it might be that you need to familiarize themselves with how it looks like seeing a psychologist or psychiatrist, or even seeing a GP, and thinking about that might be a bit different from where they're from. And they may have also, I guess when I was talking about those adverse events with authority figures, it might be quite traumatized by that. And so it might be talking about how it's affecting them now rather than any specifics about any traumatic events, so that they don't feel uncomfortable about explaining things. You can keep them feeling safe. And if you feel that there is really a trauma and torture history there, it might be about referring them on to STARTS, who specializes in that area. So there's a lot of, I guess, reflective practice, thinking about that power difference and how we can help reduce that and make them feel safe, and explain and encourage them to talk to us about what's going on. I've got up there the historical context. So it's thinking about things like with our First Nations people, we can speak about that intergenerational trauma. And if they've had a historical persecution, there's that mistrust of the clinician, of authority, even though we might not think that we're the same, they might see us that way. So it's thinking about how that's happened, if there's been past experiences of racism and discrimination, how that might impact on current and perceived racism, and whether or not they will come back to services. Then there might be even just practical and logistical barriers, trying to, navigate childcare, financial limitations, work commitments. And I know we might have our own limitations as well as to how we can overcome this. And I guess part of it is just working with their priorities. Um, um, and I guess it might be trying to find providers that might help them engage better to assist them. So, like overall, I guess these implications can then impact on how they might use mental health services. So we've probably heard about cultural safety and responsiveness, I guess, talking about our First Nations people before, and we might have also done training in cultural competency. And I guess when we're talking about these cultural implications on mental health, it's kind of highlighted what we might consider, what we might need to consider when working with CALD communities. And we can, I guess, take this into account by using sort of culturally responsive mental health care. And the training we might have done, there's a bit of an evolution of training when we're talking about this in working with CALD communities. We've kind of gone from being culturally aware to being culturally competent. And now we're sort of building towards being culturally sensitive, safe, and responsive. And so when we speak of being culturally competent, it can seem like we've done a one-off training and that it's sufficient. We've ticked off a box and we've reached that, I guess, competency. It's like a technical endpoint, but it feels like it reduces human behavior and experiences to cultural stereotypes. And it's not recognizing that there might be differences within cultures and that, there are very individual experiences people have with mental health issues when we're considering the transcultural lens. So we need to be more than just being competent. And I guess the idea of cultural safety emerged in the 90s, where Maori nurses found barriers in being clinically effective as a result of that inherent power imbalance. So what we're trying to do is trying to attend to those power dynamics, the systemic discrimination that might be accessing limited by language barriers, that health inequity. And it's us health professionals being aware of this and consider this in our engagement with that person and that interpersonal power difference between ourselves and the person in front of us. So it's having that sort of reflective practice as we consider how we might empower that person to make them feel safe. And so it's more than just learning about cultural customs and being competent, because obviously if we see one person that's Chinese, it doesn't mean that the next person that we see who's Chinese that we can apply the same sort of treatment or medication or what it might be. But we've got to think about that there might be individual differences. And so it's also examining ourselves, that potential impact of our own culture on clinical interactions. So when we're being, I guess, when we're talking about cultural responsiveness, it's cultural safety at its core. It's very transformative by incorporating that knowledge, that awareness of our self-knowledge and behavior, translating to how we might be with someone and what might we doing to show through our actions. It's the approach we take in engaging with people, how we act to embed what we learn in practice. It's that genuine dialogue that we're trying to improve practice and health outcomes. And this goes hand in hand with trauma-informed care principles of providing that empowerment, the choice and control, autonomy, safety, trust, and collaborating with that person in terms of their mental health care. And I just wanted to add also cultural humility. We all come with our own history, stories, heritage, and cultural humility is about that willingness and that ability to listen and learn from people about their lived experience. So it's that openness to understanding another's experience and awareness to our limitation in that understanding. So it's not a catch-all strategy where one size fits all, and it's more than that. And so when we think about Aruna, how could we make her feel safe? Thinking about that power dynamics, how can we mitigate it? And just thinking about that when we're talking to any individual. Um, so, so how can we best support COG communities? So, to summarize, I guess, our discussion so far, we need to consider the person's unique cultural needs, be aware of the differences that can exist within cultures, and that subculture and identities can exist. So thinking of that intersection of age, cognitive abilities, gender, that can create a very unique experience under specific circumstances. Thinking of Aruna, whether she was from a rural or urban background, didn't sound like she was college educated. She might have been. The mental health history in her family, being female, alone, no family. What expectations and issues then for that, and what have they now subsequently, arisen for her while she's been here in Australia. So thinking about, I guess, those family and cultural values and how that might arise in assessing her in this context using that systemic or ecological framework. Is there any sort of interdependence with the Sri Lankan community or any spiritual or religious beliefs, and how does that impact her in her upbringing or currently as well? Um, and I guess the other thing is to think about her resilience and coping strategies. How can we sort of incorporate that when we're trying to support her? There might be some particular strengths, abilities, coping skills. If she's religious, she might find prayer useful, or it might be having mindfulness that might be able to complement something in terms of the health system. And then language and cultural barriers, thinking about how can we reduce these barriers to reduce those misunderstanding and misdiagnosis, to improve clinical care and increase levels of disclosure. And interpreters help mitigate quality and safety risks. I know, like a lot of clients like to have the same interpreter, and it does help. And making sure that we've also got the right potential dialect. I know sometimes they just get the same person, the same like Arabic, but it's actually different. One gentleman was wanting an Egyptian because he was Egyptian. He needed the person that spoke the Arabic that was Egyptian. Rather than someone that was of Lebanese background. And it made sense because it's not going to have exactly the same words. And where we can, we try to have, provide the support that they can have, because we don't want to have any sort of misunderstandings. And it also may be, it might not be an issue for Aruna, who we're talking about as well, but there might be for others. And maybe a cultural broker might be helpful too, to help you better understand Sri Lankan culture for Aruna if you didn't know a lot about it. And you can contact our services, Transcultural Mental Health, to help sort of facilitate that interpretation and negotiation of non-linguistic cultural content and differences. And I'll talk through that in a moment as well about that particular service. But it's really just remembering that each person's experience is quite individual, and it just provides a bit of a piece of the puzzle by providing that information. I haven't got it up there, but oh no, I do confidentiality. So it's really making sure that they understand confidentiality, because I guess some possible issues arise, especially when we're talking about small communities, but we need to then make sure that they understand what we're talking about, being quite explicit, addressing any concerns, being clear about what's being recorded and why you might break confidentiality. And it might be about explaining it in different ways, as it might not be readily appreciated, and ensure that they understand that. And I'll talk about, you might have heard about the teach back strategy, and that can be a good way to try and make sure that they understand. So just getting them to repeat it back to you. When we think about that relationship that we might have with someone, it's thinking about being quite sensitive and respectful of their cultural practices, so that they can engage with us, have that trust, feel empowered, and be able to come back and see us if they need more support, and not leaving it to the last minute, like we saw with some of, attending to mental health services when they're in an acute mental illness sort of phase. And it's often just going back to our basics, appreciating some of the our pre-existing skills around being empathic, warm, in our verbal communication, not to be premature in our intrusiveness, and really building that trust and ensuring that when they attend our service or your service or another service, then we're enhancing that continuity of care by giving them a good experience, and then that means that they will come back again. And it's having that patience and flexibility to allow them to explain what might be going on for them in their own words, and at their own pace where we can. I know time can be really hard, but it's really trying to minimize that non-disclosure, and empowering them by listening to their story, or, directing them to someone that will support them through therapy if that's needed. And I think I mentioned this already around using those trauma-informed care principles when we're engaging with them, giving them that empowerment. So it's really just trying to overcome some of these barriers, around trust and privacy, because they're quite pervasive issues that can influence someone's access and engagement. So we need to make sure that we can build that caring, connection, sensitivity, and respect of their cultural practice, and make sure that they feel listened to. So I guess it comes back to that reflective practice, being aware of ourselves. Are we, thinking about, we've got all of these, got our prior knowledge and skills, so we've got our strengths, but thinking about also what might be our biases, our prejudice, our attitudes, acknowledging some of our limitations, and really increasing our self-awareness. How do we influence that person in front of us? And how is that person in front of us influenced by us when we're having these conversations and making discussions? It's making sure that we're making no assumptions, or impose any sort of ethnocentric values or put in unnecessary interventions. So I guess in sum, we just need to remember that context, our communication style, working collaboratively, and develop that cultural understanding, and remembering that hearing other stories is not the same story for everyone, and it's understanding that the power of hearing more than one story. And I guess the key is your communication, to build that confidence between you and the individual, so that you're enhancing that continuity of care, so that they'll come back for services if it's needed again. Okay, I just thought I'd pause and see if anyone had any questions, or if there was any questions anywhere. No, it doesn't look like it. Before I kick on. Nope. Okay. All right. So what are some culturally focused resources that can help support you in your work with CALD communities, migrants, and refugees? So these are just some of the ones that I'll talk about, and it's only, I guess, the tip of the iceberg. And it's always thinking about how you might use these, because it's trying to make sure that we can distinguish between sort of diagnosing someone, or someone that might be just suffering from some distress. So it's really trying to find that, I guess, cultural almost flavor around someone's presentation, and trying to see how can we make sure that we're thinking about this person in the context. And so the other thing is that we'll share links for these tools at the end, or after the session, so that you can access them quite easily. So the first one is the Kleiman's explanatory model of illness. And it's a good starting point, because it can give you that idea around culture as context, collaborate with the individual on how you might formulate the concerns, because it provides questions. So you try to gain insight into that individual's worldview, their culture, social context, and spirituality. Thinking about what's most important for the client in terms of their health, illness, and care. It might be saying something like, what have you been doing so far and for Arun, it might be for your worry or your sleeping. And you might get a bit of an idea of what she might have insight into her beliefs about what might be causing it, or what she might think might help. And I guess when you're thinking about using this, it's really not, asking questions 1 to 9, obviously, but just trying to work out how can you just try to tease out some of this information, so that you can get this mutually interpretable explanation for what's going on. and being sensitive and informal and maybe less direct when you're asking the questions. And it might be asking things like what they might find in terms of the resilience and hope for a refugee. What stopped you from giving up after facing so much hardship? There might be other questions that you can ask as well, but it's just a starting point. So the transcultural assessment checklist is something that we developed a long while ago. You might have seen it before, and it's like a mental checklist for you when you're completing sort of a cultural assessment or trying to get an idea around, I guess, the cultural identity, thinking about your own self. So it's kind of reminders of some of the things that we've been speaking about. When you're about to see someone, it's asking you to consider your background, their background, and has questions. Now, I'm going to flip screens. Hopefully you can see that. This is the second page that I'm showing you, and it's just got things to think about if you had around the cultural identity, the person's migration history, what their perceptions of mental illness is. They might have particular words or symptoms that might be describing, and how you might put together a care plan for them. So it's just kind of little reminders of what might be going on for that person, and thinking about that when we're putting together an assessment for them. And if you're interested in mental health and want to delve a bit more into mental illness, the DSM-5 at the back of the DSM has the cultural formulation interview, and it's got basically an expansion of the Kleinmans. It's got a set of protocols. There's like 16 questions that you available. That's sort of a bit more specific questions around the cultural experience of illness, help-seeking behaviors, and might add to that picture that you're trying to get around their perception, the cultural perceptions of cause, the factors, and they also have an informant version as well. And we've got the link to the cultural formulation interview on our website, which will be part of the links that we'll share after. I don't know if anyone has the time or uses any translated mental health screening tools, and it might be something that you can give someone in the waiting room if you're trying to capture something, maybe, I don't know. What I find, and I'll just talk about what I've used in the past, is sometimes it might be helpful when they're not wanting to talk about it or can't articulate their symptoms. So it can be a starting point, but there are limitations when you consider sort of maybe the individual's literacy in their own language and whether it's necessary and appropriate, because you don't want to overdiagnose and medicalize any suffering they might have, especially people that might have multiple traumatic events happening in their lives, especially people of refugee and asylum seeker backgrounds. And I know even someone that might be able to read English, they might not really understand some of the terminology used. So it's being really mindful of some of those limitations. However, I mean, we do have a whole list of these translated mental health screening tools. There's also ones for younger people, children, and also older people. So it might be, I guess, a way to capture some information, but not necessarily for diagnosing, depression, anxiety. So going back to the terminology, I know I had to explain at one stage, and then I didn't use it really, was on the DAS, they've got an item, I'm feeling downhearted and blue. And sometimes that's really hard, and that is hard to explain. How do you explain that? That just changes how that tool would be used. So it's, or I find it difficult to wind down at the end of the day, or something like that. And it's trying to translate that. They can speak English, but they don't understand that. So some of the cultural nuances, even for Australians it can be very hard. So it's just really thinking about it when we're using these tools, and how, I guess, accurate the information is in capturing that information that you're wanting. So as you know, as we know now, is that health literacy in some CALD communities can impact their engagement with treatment. So using strategies like the Teach Back strategy and the Learn model can help improve communication and build coping strategies around mental health. And hopefully this is kind of second nature for us, but sometimes we forget. But this way we can correct those misunderstandings this way. And this tool's kind of been endorsed by New South Wales Health. So it's kind of just, I mean, and some of this might be like, well, a bit more of like a, oh yeah, this makes sense, or this is of course, sort of moments. But using plain language, rephrasing your message, focusing on 2 to 4 points, and starting with the most important message. I mean, you could think of using this for confidentiality. So when I need to tell someone, explain someone. Oh, sorry, I'll just put that example up so you can't see. I want to make sure that I explain confidentiality clearly. Can you explain to me? And then get them to explain it back to you. And then I guess there's the learn model, which is just another sort of heuristic that you can use to help eliminate those communication and culture barriers between patients and health professionals, and improve that engagement. It's like listening to their perception of the problem, and then you explaining what your perception is, and both parties then acknowledging and discussing those similarities and differences between the perceptions, and then providing recommendations for treatment developed. And then the negotiations are about, well, trying to get to an agreement, facilitated through questions and answers. So it's really, adapting it for your use to help sort of reduce those miscommunications. What else? So there's some technology tools you might have heard of. There's the multicultural New South Wales Health's multicultural health communication services. On their website, they've got the Cold Assist app, which is a free communication app to support patient care. You might have come across it. It's not to replace interpreters, but it's for sort of things that are low risk and basic care. So just check for fit for purpose. And it might be at reception. Do you need glasses? They need to take a blood test. Those kind of things are the sort of the phrases that you can see. Then there's a translated appointment reminder. So sometimes some people may not turn up to appointments because they've got no idea they've got an appointment, or they've been given a reminder that's in English, and so they don't really understand. So there's like a translated appointment reminder. It's on the website for the Multicultural Health Communication Service, and it can be translated. So these are emails or SMSs or a PDF, so you can print a letter and send it to them. And I was using it for SMSs and emails to clients, and that was really helpful for them. So you can go to their website and check that out if you think that will be helpful for some of your patients. As well as translated resources to sort of help educate and improve literacy. So this can sort of help, normalize it, that it's not just me and that it's quite common. And you can go to the Multicultural Health Communication Service. They have not just mental health, they've got other health information available. Embrace Multicultural Mental Health has a whole range of them, and they're kind of like, I guess, a more national one of us. So they're all about multicultural and transcultural communities, but they're the more the national organization. And I'll talk about TMHC in the next slide. And I guess the other thing, and you might know more than I do around what's sort of local to you, in terms of community organizations and cold specific organizations. So when we're talking about looking after someone, we're thinking about their mental health, it might be thinking more, and they might be more from a more community based sort of culture rather than an individualized culture. So it might be helpful to think about what kind of community organizations might be helpful. So really thinking about that within that systems thinking around that. What I was going to say was on our website, we do have some listed on there. Otherwise, you can get in touch with us and we might be able to lead you in the right direction about that. I don't personally know all of those things, but my colleagues I know have that information that they can share. So we're not just translated resources. This is sort of, I guess, a model, and it reflects this multi-pronged public health approach. And we support, as I said, cold communities and service providers. This is currently what our services and programs look like, but it's ever evolving to meet the changing needs of cold communities. And we all work together in conjunction to provide that effective delivery of mental health care to culturally diverse groups, because it needs those multiple interrelated components. And I guess just to focus on sort of the ones that might be helpful to you is the the red one, the specialist clinical services. So we've now got two services. One of them is the clinical consultation and assessment service. Oops, I've gone too quickly. I've scrolled too fast. That is kind of internal to public mental health service. So if you've got a client who is being seen by public mental health, then we kind of supplement them. So if they're being seen by the inpatient unit, we can provide that cultural assessment to them. So it's only really internal, but you can actually contact them if we can't consult specifically on a particular client or patient, but we can provide that cultural consultation. So it might be, you might have a Runa, don't really know a lot about how that culture works in terms of mental illness. And so you might contact us to find out a little bit more about Sri Lankan culture generally. And that might give you a bit of a piece of the puzzle around what's going on for Runa. We also have the transcultural mental health line, which you quite saw briefly, but I'll talk about that in a sec. We also have the mental health promotion, prevention, early intervention, and this sort of works in partnership with other services. So it's more around community promotion. So we can provide in-language mental health literacy sessions to help reduce that stigma at the community level. And we also have open carer support groups. So I know there's a Cantonese one in Campsie, there's Dari Farsi in Granville, and those are open to anyone. People can self-refer, but if you want to refer someone, then you need to get their consent. And we have all that information on our website. The education, training, and clinical supervision. So that's, I guess, where we are at this evening. And we provide longer sorts of training because obviously you can tell that there's so much to this space. And if you wanted more workshops, a deeper dive into this area, then we will be running training down the track as well, or you can contact us if you want any particular sort of training. And then we also have multilingual multimedia resources and publications, which I think I have a separate slide for. And I guess just to quickly talk about the yellow and the, I guess, beige circles, they're kind of, I guess, in the background, but they're important as well to our work around policy and research. So thinking of, we provide that policy consultation and advice in the local, state, and even national levels. And then we also partner with academia to build and identify those research gaps for cold communities. So the transcultural mental health line, it's a new service. I think it came in October. No, not last year, the year before, actually. Oh, time flies. So basically, it's a direct service to clients and consumers who aren't linked in with mental health services. And we can provide mental health information around services, accessing services, or even short-term intervention. But it's not a crisis service, but it can support, say, families and carers who are caring for someone else. So the numbers on the screen, as I said, it's not a crisis service, and hence why the days and times are what they are. And if we think about Aruna, she might be able to call here, or it might be around trying to find services to supplement and support her mental health. It might be around getting an ethno-specific or religious-specific sort of organizations, if we're interested in that. And say you have someone that may not be able to afford treatment, psychological treatment or therapy, they can call this service if they feel comfortable with it, because it is a phone service or a video conferencing. It's not face-to-face, and no Medicare is required either. So we have, I don't know if I said this out loud, but there's over 30 languages available. So we have a pool of clinicians that work with us. And full-time who are there during those hours. We have a Vietnamese, Spanish, Mandarin, and Nepali clinicians who are there full-time as well. So that's all I think I needed to say about the Transcultural Mental Health Line. And no, I can't click forward. Okay, here we are. And then these are just some of our just pictures of examples of our translated resources that can be downloaded, or you can contact on the email address for free, reasonable amount of printed copies of resources. And we've just we recently updated some of the new and emerging languages, including Nepali, Pashto, Burmese, and Ukrainian. And it's really about building that mental health literacy and supporting normalizing that experience. And we start with things like with like sleep and stress, because it's kind of non-stigmatizing, it's palatable. And I know with some of the Afghan refugees that I've worked with recently, they found that easy to bring home. It's only just around sleep and stress, which, even with, I guess, recently with COVID, that seems to be something that's easily palatable around mental health issues. And our website also has, as I've kind of mentioned, we've got community mental health profiles. So you don't even have to call us. You might find something on our website to help inform that picture of an individual story. So we've developed some in response to recent crises like Syria, Afghanistan, Ukraine, Iran. And we also have things that are for older people from cold backgrounds. And we also launched last year one specifically around our LGBT QI plus communities who are from of cold background, because we know that there's layers of discrimination, prejudice, and stigma that can happen for those people in those communities. And so, you could provide Aruna, but she might be able to read English well. I don't think there's anything in there, or she might find it easier to read in her own her language, and it can build her mental health literacy or give her some information around improving her sleep. And as I mentioned, the TMHC is ever evolving. So this isn't in the original flower diagram that I showed of us, but I thought I had better mention it because I sit in this program specifically. And we're a statewide program, and the focus is on better outcomes for the mental health of refugee communities. And so we've got the two components that work in tandem with the community capacity component. So basically, working on the grassroots level, trying to engage with communities to prevent mental health issues by promoting good mental health. And then hopefully that's increasing access to mental health services when it's needed. And then the clinical component where I sit, it's about building the skills, knowledge, and confidence of supporting and strengthening the skills of health services so that they can provide mental health services, responsive mental health services to newly arrived refugees. So someone that might be a refugee, they benefit, indirectly from this program through mainstream mental health clinicians improving their skills, working with communities to build mental health literacy, and so that they can be sufficiently cared for within usual mental health services. But I guess it's always going back to, seeing what person wants and building that engagement first, knowing what is it what's important for that person if they were a refugee. Okay, so we'll come back to Aruna's story again, and just adding to her story. So that hasn't changed, but this part, you've decided that Aruna is experiencing symptoms of anxiety and would benefit and should benefit from some psychological intervention. You begin the process of doing a mental health care treatment plan, as you do not have time to finish the plan in one consultation. You have only 10 minutes in the consultation, as there are a number of patients in the waiting room wanting to see you. So, how are you going to build rapport with Aruna? How are you going to explain the diagnosis of anxiety? And how will you explain the possible benefits of psychological counseling? So what I'll do, I'll put those questions in the chat box, and then I'll show her story again and give you a couple of minutes to kind of think about how you would respond. As written, she's known to you for her other medical conditions, so rapport building may already have started. Yes, that is true. And I guess it's just building on that, which is really important. And then acknowledge that it must be hard for her, and to tell her that I'm happy to help. Yeah, especially if she hasn't disclosed that before, it is really important to acknowledge that. And sometimes it's quite not, like, I guess, nice to hear that from someone. Good listening and politely working out when to have a longer appointment. Yes, and that's always the hard part. And time is always really, really tricky. We need a few visits in the beginning to understand fully her needs. Yes, and I guess that's a really hard part when you don't have that time, because then you can't. Then it makes it really tricky to then work out how Are you going to work through all of the information and build that rapport, and have a good, solid understanding of whether or not, whether or not that diagnosis is correct and accurate too. Aruna's mom had anxiety, so easy to explain. Aruna also has same condition, and help is available, and to give her a longer appointment and give her online anxiety management. That's good options because yes, she has already kind of acknowledged that something's gone on with her mum, and has had anxiety and did what she had took medicinal herbs. So it kind of helps that socialization to mental health issues. Okay, so I think, I guess, it's kind of building on that, how will you, I think we've kind of spoken about how you're going to, so I just wanted to check if there was anything else in terms of building rapport. I guess the other part is letting them know, like we're talking about those longer consultations, but it's also about what are you going to do in those longer consultations, explaining why you're having those longer consultations as well, and really giving her that time then to listen to her story, or to anyone's story, and normalizing it. I don't know if anyone said that part. So how are you going to explain that diagnosis of anxiety? I think someone has kind of answered that about her mom. Is there anything else that you would add to that? Optimize her physical health as well, and her diabetes, the back issues, and arthritis. Yes, it's really that tired, making sure that we're looking after both the physical and the psychological, and remembering that they're not separate, and that might be also helpful to around her anxiety. And if there was any other takers on how you're going to explain the diagnosis of anxiety, other than, I think, it would be good to explore what are her words for ease. Absolutely. Because then you can use that, and it can help reinforce what's going on for her and what's specific for her. Especially if, and it might be using that instead of anxiety too, potentially, even though you're going to try and explain what's going on for her, it might not actually be using. And sometimes when I see clients, I don't necessarily, just depends the diagnosis per se, but giving them the picture, the formulation, the idea of what's going on, and understanding what's reinforcing their low mood, potentially their anxiety, and what kind of things they can do to stop or prevent that reinforcement of those psychological or mental health issues. It's just added, and how magnitude of worries can change and become harder some days. Yeah, and how it can, and yes, I guess that's kind of what I was going to say, was acknowledging that it's a difficult situation, and it can be a response to a difficult situation, this anxiety, this worry, and that it's, and you can always say that it's just a common word, that's sorry, it's a word that is commonly used to describe a pattern of symptoms. And so how will you explain the possible benefits of psychological counseling, as the last question? Written, I guess, in response to the previous question. Anxiety is a defense response of a body. However, when it's intensive and continual, it becomes uncomfortable. Yes. Any takers on the last question? How will you explain the possible benefits of psychological counseling? Written, counseling can give more time to explore and help learn ways of coping. Yep. And potentially, I guess it's that creating that sense of hope, the benefits. It might give them a different perspective on things. And I guess it comes back to that ensuring that discussion around confidentiality when they go to someone for psychological treatment or counseling. I guess one more thing is just checking that their understanding of the health system and your role, trying to, because I know some of the people that I've seen that are newly arrived expect a lot from the GP and doing everything. And it's really trying to make sure that you can demarcate what's done with a GP, with a psychologist, with a counselor or a social worker or whatever, or a nurse, that might be a bit different to the health system they might be used to. I guess to add as well, I've put down arunas from Sri Lanka, but it's making sure we don't make any assumptions that there might be diversity within cultures. As we said, urban versus sort of rural area. It might be exploring religious beliefs around coping mechanisms. Look at previous coping and strengths. And as someone's already said it, sorry, I can't remember who it was. I think it might have been the sneaker, about the significance of the disclosure and highlighting that, and how hard it might have been to share that information. Okay, so I think we've kind of gone through all of those. I don't think, so how are you going to build rapport with Aruna? I think we've said all of those. How are you going to explain the diagnosis of anxiety? And also, how will you explain the possible benefits? And I think we've said all of those things. So if there's anything else you wanted to add, feel free to add it to the chat box. I guess this is like the second last slide, I think. So what is our role? Reflective practice is central to our clinical work generally, but even more so when we're working with vulnerable communities like COG communities and migrants, and in particular, refugee and asylum seekers. However, it's not just about the person in front of us. It is also reflecting on us as clinicians and health professionals, and also as individuals and our biases, beliefs, and attitudes. So I just wanted to close with some of these ponders. What approaches do I use already to help me work with individuals? How can I improve my engagement with individuals by considering the influence of culture on mental health and mental illness? And what can I do differently for the people I work with? We may already take that person-centered approach, which means we build trust, rapport, take an interest in that person, might use a biopsychosocial framework and consider those social aspects. But we might need to take that broader perspective, identifying what their priorities might be, what their capabilities are in the context of their story, and factors that might be outside of their control. So we need to be cautious about how we might impose constructs on others who are not better or worse, just different. And we may help them as health professionals by acting as advocates, as things might lie outside of their control. So I just want to finish on, be aware that we all have culture and that it influences the person in front of us, ourselves, and our engagement with others. It is more than just knowing about a culture. It's about making that person feel culturally safe through being culturally responsive so that we can support them and their mental health and well-being. So that's it from me. Does anyone have any questions? I hope you found this helpful, and at the very least, giving you some space for reflection on your skills, knowledge, and confidence to work with people of diverse cultural backgrounds. And so just as a reminder, it's all about self-care, that this is just a starting point, your professional development as well. So feel free to get in touch if you want more in-depth training or information, more than happy to connect. About from her experience, unfortunately, some interpreters are not translating correctly. I totally understand. I remember, like, I can't speak another language. I can understand a couple of dialects. My parents are from the Philippines, and even in my own experience, I was like, they're not translating what I'm saying correctly. When I had a client of the same background or language, and it can be really hard, and a lot of it is and this can be quite hard, is feeding that back to the interpreter service, any sort of feedback. Because I know that within where I work within the local health district in Western Sydney, that's what the interpreter manager had asked me to do, was to make sure that we fed back so that they could then feed that back to the interpreters. And I always, when I have a good interpreter, I hang on to their names and make sure that I use them again, and also provide that feedback to clients, not to clients, to the manager. And that's the best that we can do for the moment, at least, because in that way they're finding that feedback, and then hopefully that can improve experiences. Because we don't want to not use them, because we find that our experiences are terrible, but we can't improve that if we don't give that feedback to the services themselves and their managers. So I completely understand, though, is what I wanted to say. But that's what I've done in my experience.
Hope you all have a lovely night, a lovely rest of the evening. We'll see you next time.